Hi, I'm Dr. Lisa Konick at Konick and Associates. Welcome to our Ask an Expert Parent Education series on recognizing the warning signs of risk in teens. This is the third segment of our series, and today's segment is going to be featuring depression and suicide risk in youth. Today I have with me Amber Konopa. Amber has been a trooper through this series. Thank you, Amber. Amber is a clinician at our practice. I'm going to introduce Amber in a moment here. I first want to let everyone know what we do at Konick and Associates. We are a family behavioral health practice located in Naperville and Orland Park, and our clinicians specialize in research-based treatments across the age span, starting as young as 3, and we specialize in the treatment of children, teens, and adults, as well as comprehensive psychological and neuropsychological assessments. And Amber is one of our clinicians. Amber specializes in substance use, co-occurring problems, anxiety, depression, challenging behaviors, and treatment-resistant issues in adolescents and adults. She is a licensed clinical professional counselor, a certified drug counselor, and a certified recreational therapist. Amber, tell us a little bit more about you and how this talk kind of relates to your experience and why you think it's important.
Thank you. Hello, everybody. I'm Amber, as Lisa said, and this is a very sensitive topic for me and for a lot of colleagues that I know. And suicide doesn't just affect loved ones as well. It also affects the people who are seeing the clients and working in various settings throughout my 20 years. The impact of when someone dies really sticks with you and whatnot. And as I was looking up information about this sensitive, serious topic that needs to have words to, because it's so uncomfortable for many people, including professional people about this, that I saw a quote, and I've been watching the TV show 1883, and Sam Elliott, who is Shay Dunham, he has this quote, and it really touches on not just with suicide, but also death and loss. And it says, when you love somebody, you trade souls with them. They get a piece of you, and you get a piece of them. But when your love dies, a little piece of you dies with them. And so I was like, well, love with counselors, well, love can mean many different things. And especially when you develop such a safe and trusting relationship with another person, which is part of the therapeutic process, that people share their intimate, most sensitive place. And when you're showing people how to be safe and that, you know, it's okay to talk about what's in the dark and what's sometimes buried down, that really, that's a place within me that I take very seriously. And you develop that tenderness with somebody. And my way of representing the people who I've experienced died due to suicide, my way of honoring them is by doing what we're doing right now, is education, because education breaks the stigma. Education helps people to be able to communicate and to show and model this is how we do it. And so when I'm in counseling, when people come with such loss and despair and not knowing where to go and what to do because of feeling stuck in a knot for so long, I like the Gandhi quote that part of my way of teaching people is for them to see the gifts with, like, how does it go?
To be the change you wish to be in the world.
Yes, because so many times you don't see that, and so it really, when you can show somebody their strength and to show someone that empathy, it really shines a light. And another really cool aspect to counseling is I bring a creative approach because I'm a recreational therapist. And so when I've been working in outpatient, I tend to have done, and inpatient for that matter, tend to do creative drawing but I actually created a creative recovery music part of the program. And it's amazing how music can really bring out where sometimes things have been buried or it's uncomfortable to share. And I'm telling you, Lisa and anybody, music touches lives. Music is therapy. And it's amazing to see how I can be so locked in with me and yet share with another person, and to understand that I'm not alone, because so many people, when they're in that despair place, they feel alone. They feel disgusted. They're consumed with so much shame and fear that and music has a way of touching on that. So if you're out there and you're experiencing something that we're talking about, music can be a great way, and also to find a counselor that has a way of touching on those places that need to be talked about. So,
and I appreciate that, Amber, too, because I know, that's a way that parents can also connect with their teen, even though they may not like the same music as their teen.
right,
It is a way that I think we can talk about that when we talk about protective factors and what a parent can do in the case if they're concerned about their teen being at risk for either depression or suicidal behaviors, is how do we connect in attend to our kids' interests and kind of understand where they are and be with them in that place. I want to touch on, why another reason why we're viewing this topic as important and timely right now is not only that this has been an issue, and I know Amber has some statistics to share about risk, but also like how has COVID impacted the risk status of our youth. And it's interesting with teens. I am seeing in our practice a lot more social anxiety. Kids have been isolated for so long, and the social anxiety, even in kids that haven't previously had social anxiety before, kids that have previously been relatively social, are experiencing more stress and anxiety. And Amber and I talked last week in our last talk on substance use and neurobiology of the brain, is those feel-good chemicals that are naturally produced when we do things and we interact with others have really been limited with COVID and the pandemic. And then getting back into the world, there are so many changes and stressors that kids are really struggling with motivation. And we're seeing more kids stressed and depressed currently for multiple reasons. And more students right now, we're seeing reporting low mood, apathy, challenges with motivation, and social isolation. So I think this is a really important topic. So Amber, with that, can you give us some statistics regarding suicide in the United States? And I know you did a little research on this.
Yes. And as I was researching this, I was also blown away by the statistics. And since working with you at the practice and my clients and what I'm seeing, it's amazing what COVID has done, not only to teens, but also the world in general. And so one place that I went to was I believe it's the NIH,
National Institute of Health.
Thank you. They say the suicide is the leading cause of death in the United States and a major health concern, which is another reason why it's important there needs more of these type of discussions out there, because a lot of times it's not discussed. The CDC in 2020, suicide was among the top 9 leading causes of death for people ages 10 to 64. Suicide was the second leading cause of death for people ages 10 to 14 and 25 to 34, which was chilling. It's one thing to see, people and experience this, but then to put the number to it, and we're not into scare tactics. These are the facts that's out there and why this is so important, because, again, and then the WHO, World Health Organization, suicide is the 4th leading cause of death among 15 to 19-year-olds.
These are alarming, and I do think what we want to do with this talk is to help people understand how, let's demystify the myths, because there's a lot of inaccurate information about this, and people have some inaccurate thoughts about What happens if I talk to my child about suicide? I may be making them more suicidal. So we don't want to do that. So let's go through some of these inaccuracies. And I think it's helpful to kind of understand what do we do instead. Amber, let's talk about some of these. One that you got listed here is suicide only affects individuals with a mental health condition.
Suicide not only affects individuals with a mental health condition, many individuals with mental illness are not affected by suicidal thoughts, and not all people who attempt or die by suicide have mental illness. And go ahead.
I want to add to that too. Think about what's happening in an adolescent or even a young child is we're talking about individuals that really haven't experienced a lot of opportunities to develop effective coping strategies. So minor stressors or social stressors or academic stressors or family stressors, if you have a child that, and we're going to talk about those risk factors shortly, but they're impulsive and they have limited coping. So this creates a risk even without a diagnosed mental illness.
And with our topic of teen and substance use, if I'm dabbling with substances, that impulsivity, that recklessness, that connection of, oh, this is helping me, or I'm noticing how it's taking the edge off, it's a very dangerous situation to be because of risk factors and what we're going to be covering as well. And also, once an individual is suicidal, he or she will remain suicidal. That is a myth. And active suicidal ideation is often short term and it's situation specific. Studies have shown that approximately 54% of individuals who have died by suicide did not have a diagnosable mental health disorder. And for those with mental illness, the proper treatment can reduce symptoms. That's why it's important where Lisa's you're putting out there here you can reach us. And so many times when people are in a crisis situation, they don't know where to turn. They don't know who to go to. And a lot of times families feel like they're going to manage it themselves. And again, like in our previous discussions, that's where trained professionals are really important to help that individual, assist that individual to develop those skills and tools.
And that's why one of the reasons why suicide hotlines are effective is if we can get individuals that are at risk linked to those resources, these are usually temporary problems. And we need to help individuals who are hopeless and at high risk recognize that there's support out there. So if we can help them recognize these are, it's a permanent solution to a temporary problem is what I often will tell my students. And they get it when you put it into that context and they're willing to look at safety planning, but we have to get them before that impulsive act. So some of the other risks myths that we hear about is most suicides happen suddenly and without warning. Amber, what do you think about that myth?
Well, we miss the signs because there are warning signs. And with the warning signs, they're verbal, they can be behavioral, they can be both. And the warning signs precede suicides. Therefore, it's important to learn and understand the warning signs, which we're going to get into, associated with suicide. Many individuals who are suicidal may not only show warning signs to those closest to them, these loved ones may not recognize what's going on, which is how it may seem like the suicide was sudden or without warning.
And unfortunately, I think people recognize these in hindsight. So we want to preventatively give you the education that you need so that you can take the steps to be more supportive when hopefully that won't happen in your life. But if it does, you'll know what to do. Another one that is a common myth is people who die by suicide are selfish and take the easy way out. Amber, thoughts about that one?
Yeah, that is, when I was looking at this, that makes my blood curl when I read a myth like that, because this is a big stigma associated with suicide, and many people are afraid to speak out, like that feeling of despair and feeling, because you feel like the thoughts are not you can't see the future. You feel like those thoughts are permanent. And talking about suicide not only reduces the stigma, but allows the individual to seek help, rethink their opinions, share their story with others. We all need to talk about suicide more, coming from a place of empathy, compassion, and that's not just with professional people. This is also the loved ones around the person as well. And that assists the person to look at suicide from a different angle.
There's some other ones on our list here. People who threaten suicide are just seeking attention.
Well, the attention is what they need. The attention is what they're hoping that somebody's going to recognize to help them get out of the place where they're at. And again, because of the communication and where a person is at, a person sometimes doesn't have the ability to see what they're hoping other people can see.
And adding to that, I think all kids want attention. Most people want attention. And I think if that is part of the attention seeking aspect, we're up the ante so that I can really get attention, then we need to really embrace that person's needs and say, it sounds like you're getting attention. Is this the healthiest way to get it? And let's work on some more healthier strategies to connect with people so that this isn't considered a good option for you. And that tends to be more of a therapeutic process.
Hey, Lisa, I got a question for you. So as I was looking at my research, I was noticing some sites like NAMI, National Alliance Mentally Ill, that's another excellent resource. With your experience, do you think what we're covering, these myths, are just for teens, or do you think this also applies to adults as well?
Absolutely. I think, when we're talking about some of these behaviors, it is across the lifespan. And, some of the same factors that we may be looking at a little bit developmentally at a different age spot. The adolescent issues are maybe going to be different than an adult, but some of the same factors apply, some of the same myths apply. And I think some of the interventions and risk factors are going to be consistent. Good point. The other thing I think is another myth to address is talking about suicide or asking someone if they're feeling suicidal will encourage suicidal attempts. And that's an interesting one. And the research that I've done, and I'm sure Amber as well, is one of the questions we ask in our intake is, have you ever thought about suicide? Do you have any history of attempts? And interestingly, you'll see parents' jaws drop sometimes when asked that question directly in the company of a family member. Kids will say, yeah, actually I have. And it certainly directs us to that intervention. And I think parents are feeling very anxious and uncomfortable not knowing, but it is something that in most cases, if you ask the question, you might be able to uncover it pretty quickly and simply. And I think people are afraid to ask that question. And there are maybe different ways to ask it.
Right. You can also say, are you feeling a lot of guilt, excessive guilt, or do you feel, how have you been feeling with school or with work for that matter? Are you feeling hopeless, worthless?
Those are some of the risk factors that we're going to talk about.
Right.
Another one that is young people who talk about suicide never attempt or die by suicide. And we are seeing that being contradicted by the data, with kids as young as 10, unfortunately, being on that list. And it's heartbreaking. And we are trying to look at that. I think when parents see kids changing their behaviors or acting more isolative or demonstrating some of those risk factors, they may not consider this to be as serious because they're dealing with an elementary age child. But we definitely want those kids to be attended to as well. Just a few more of these before we get into the warning signs. Amber,
could I add to that,
sure.
Lisa, as well? And when you're talking about it, you don't want to trivialize, and we'll get into the do's and don'ts of communication, but it's really important when you're starting to see that there's something going on here, it is best to get the person into counseling as soon as possible instead of waiting and delaying, because this can be a fire that can be smoldering or it can be escalating. And so if a person's already talking, there's already a progressiveness. So I just wanted to add to that it's really important to seek help or to get a risk assessment at a hospital.
Yes, or even the school counselor can be a source,
Yes.
a resource to a lot of families as well. Good point. You mentioned here, a promise to keep a note unopened or unread should always be kept. And I also want to mention that aligning with kids, if your friend is at risk in texting you and kids are like, don't tell anybody, right. This puts these peers in so much stress because they want to be a good friend to their friend, but they also are carrying a burden. Amber, thoughts on that?
I would even say, from not just working with teens, but also, Lisa, working with adults, that if a person even says this to an adult or a friend, or let's say you're a person, again, this is substance use in teens, and people are under the influence, and you now hear somebody talking about threats, and you're like, what just happened here? Again, it's reaching out, it's talking to somebody. And what I have always said over the years, young and old, is you don't want to play counselor. If you haven't been trained, you're going to be carrying an extra burden. And there's a technique in substance use counseling. It's motivational interviewing. And in a recovery tool is playing the tape forward and also playing the tape the other way. So what I always say is, all right, you don't want to say anything? Okay, well, let's play the tape forward. What happens if a person follows through? How are you going to feel? What's going to happen after that? And what's the biggest fear if you don't say something? Or the other way, if you do say something, what's the biggest fear? And so being a good friend, being a good parent, whoever the person is, part of being a safe individual is providing that person the tools and techniques and providing the resource for that person. And a lot of times it's professional help.
So the summary is, we're going to disclose to a trusted adult, to a
yes,
trusted therapist, yes. To a,
right.
A school person and a school counselor if it's a student. Yep. It is important to, and I think in the hindsight or the after effects of this, there may be a rift temporarily in the relationship, but generally there's an understanding that this person is getting some support and they're no longer going to be at risk after that, which is important.
Yes. And sorry. And another thing is what I've heard from people after it, like during, I can't believe that, there is that rift afterwards. People are very thankful. I didn't even think about how my behavior was impacting another individual. And so, and a lot of fear is I'm going to get in trouble and whatnot. And again, just to recap, no, a lot of times it's people are, again, the humility, the empathy of the compassion. It's a compassionate act is to advocate for that person.
And I think the message of, I care about you and I'm going to, yes. This is bigger than me. I need somebody that we can rely on to get you some support. So I think that is an important step.
And Lisa, don't we as clinicians act as a treatment team as well? So not just with young people and adults who are like, I'm not even trained in this. I don't even know how to approach this. As clinicians, we don't make independent choices on our own. In our staff meeting not too long ago, right? Let's talk about risk. How are we going to follow through? And it's important to have a team because we can't do it alone.
And I think when I think about our team is the parents, the individual, yes. That's the client, and the school.
Right.
We want this individual to be secure and safe and have a good safety plan across settings. So I think opening up those conversations is certainly extremely important. And I think it helps the person to feel cared for, even though they may be resistant in the beginning, we're putting together a safety plan. Another one that's an interesting challenge is if somebody does attempt suicide and they survive, I'm looking at my note over here so I read it properly, they will not make a future attempt. And interestingly, what we do unfortunately see is a suicidal attempt puts you at risk for a future attempt. So we definitely want to be intervening with some very important safety skills, coping strategies and interventions for that person so that suicide does not maintain in the back of the mind an option that they are willing to entertain.
Right.
Anything you want to add on that, Amber?
Again, we're going to highlight the risk factors and warning signs. And again, it's seeing those warning signs, it's understanding, and the best way to do it is to talk about as I teach, another tool that I teach people is it's learning to get comfortable with the uncomfortable. And part of that is learning how to have a talk about this. So hopefully this reaches a lot of people and we're showing how here's some ideas on how to talk about this. So that way it's not too late.
And I think we can move into the warning signs at this point. Let's talk about some of those factors that contribute to increased risk. I think one of the ones on the top of the list, even though we had made a comment a little earlier that depression, there isn't always a mental illness or a diagnosable condition. Depression is one of the risk factors for attempt or suicidal thoughts, I should say. Adjustment issues, substance use, those are typically a higher risk, as well as conduct disorders. And oppositional behavior. So those high risk mental health problems. And I do want to talk about depression symptoms in a cluster because they are risk factors as well. And right. Not everyone that is depressed is going to have suicidal thoughts. But those two, if somebody is suicidal, they could be depressed as well. So we want to make sure they're linked. Some of the things that the warning signs for depression would include major changes in sleep patterns, either too much or too little sleep, sudden and extreme changes in eating habits, such as excessive eating or losing a lot of weight, losing your appetite altogether, not feeling like eating, eating much less, withdraw from friends or other groups of people that you tend to spend time with, dropping out of group activities, major changes such as nervousness, outbursts, impulsive behaviors, irritability, particularly in teens and youth. We see depressive symptoms not only as sadness, but as irritable and emotional outbursts. Unexplained tearfulness, feeling overly emotional over minor things, lingering expressions of feeling unworthy or worthlessness. Amber mentioned guilt and shame, unnecessary or excessive guilt, prolonged anger, lack of interest in the future. And I think this is one of the most important connective indicators of risk is hopelessness. So we can have somebody that's depressed and has a number of those symptoms of depression and may not be thinking about suicide. They may be at risk for other things due to their depression, but the hopelessness piece is one of the things that I've worked on in my research, is one of the higher indicators that there's no future focus, no goal focus, no hope for the future. Amber, any thoughts about some of those factors?
And what I was thinking is this also goes with adults too. Mm-hmm. Again, and a lot of in some people, and not to stereotype genders, whatever, because there are stereotypes attached to this. Like when I was taught in 2001, when I first got out of school, and my first psych job was at Westlake Hospital, and my supervisor said, "What are your stereotypes with the different mental health disorders?" I'm like, "What are you talking about? I am empathy. I feel it." And he's like, "You got to get in touch with those stereotypes, Amber, because we all have an idea." And a lot of times women can be also angry and irritable, which can be a sign of depression, and men can get closed in and go within. So it's also important to understand the individual. And a lot of times the behaviors are showing themselves too. And sometimes it's hard to put those words to it as well. That's what came to mind. How about you, Lisa?
I think that's an excellent point, Amber, that, I think sometimes we write off some of the behaviors as based on stereotypes. I think of, males are much more accepting of being irritable and angry. There's a negative word for girls that are irritable and angry. We don't like that word. But either one could be signs that something's troubling an individual. And I think we need to be mindful of not to write off some of those things as overly emotional, for example. So I do think that's a great point. Amber, tell us also, as we're kind of talking about the depression, what are some of those additional warning signs for risk for suicide over and above those depression symptoms?
A recent suicide or death by other means of a friend or a relative, previous suicide attempts like we already covered, preoccupation with themes of death or expressing suicidal thoughts. And if I may pause there for a minute, sometimes music can be a little like you're hearing this song and what are the messages and what is going on. And that's why it's important to have a dialogue. And you may have a person say, "You know what, this is really expressing what I haven't been able to get out." So sometimes music can be a little like, "What's going on?" At the same time, that's why communication is important.
I do mention, as you mentioned that, Amber, we see that shift in kids, and that's something parents may want to be attending to. Like when you know your kid's musical interests, and then you see it shift, and it gets very dark and moody. That may be a sign that they're feeling depressed, and they don't have words for it, and they're relating to that artist or those lyrics. And having conversations around that, I think, are really important.
Yes.
Bring up those types of topics with your teen or your child.
Absolutely. Giving away prized possessions, making a will or other final arrangements, a sudden lifting of spirits when there have been other indicators may point to a decision to end the pain of life through suicide, difficulties relating or understanding people, difficulties perceiving changes in one's feelings, behavior, personality, feeling trapped, acting agitated, anxious, and having great feelings of shame and guilt.
Yeah, and I think being mindful, and I want to put a caveat here that these in and of themselves do not indicate that this is a dangerous place for an individual. And we don't want people thinking, "Oh my goodness, my kid's doing some of this stuff." But it is definitely something to be considering, that it's maybe worth a conversation, and having ways to address that, and noticing that there have been changes, and seeing if maybe they want to talk to somebody about that.
Absolutely.
The other thing I think that it's important as we move on through this talk is, let's talk, those were some of the warning signs. Let's talk about the risk factors, because those are important too. And
Yes.
we look at risk and protective factors when we're doing an assessment for risk of an individual for suicide. So as a clinician, those are part of our overall risk assessment, part of a risk assessment that you would get with any mental health provider or level of care assessment at a hospital. And we can talk a little bit about what that might look like. But let's talk about what some of those factors might be, Amber.
Sure. A family history of suicide, substance use. Again, drugs create that mental high. It hijacks the brain and doesn't work with the prefrontal cortex to think, and especially with teenagers, the thinking and impulsivity is already at a certain state. And that can also, and lows that worsen suicidal thoughts, intoxication. More than 1 in 3 people who die from suicide are under the influence of alcohol at the time of death, which is
And I think that
unbelievable. Unbelievable.
the challenge with the alcohol, especially as a depressant, is it's disinhibiting. So the person that may have said, well, I would never do it because I, wouldn't want to hurt my family. I wouldn't want, when they're under the influence of a substance that's disinhibiting them, they are now more dangerously impulsive.
And what I've heard over the years, young and old, is, well, when I'm under the influence, and alcohol is one of those finicky substances that in society and culture tends to really minimize it. And it's amazing where people say, well, alcohol gets out what I need to feel. Alcohol and substances gets out what, I need to say and whatnot. And that can be a real risk with the link with what we're talking about and, other coping strategies and whatnot. And that's where counseling can really assist the person and the tools to see that, hey, all this is doing is, because it's a depressant, it's actually making my mood go down, not up.
Yeah, and that's a dangerous combination if they are,
Yes.
it's intensifying a negative mood,
Yes.
it's intensifying hopeless feelings, and it's creating a disinhibition that's likely to lead to more impulsivity. That's a dangerous combination. So
then you add another relationship to that is firearms. And many people are this is a very sensitive topic for some people. And having access to firearms, access to means for self-harm, unsecured firearms, prescriptions, medications, or poisons. Teens are impulsive, poor problem solvers, and immediate means are the most lethal. And that's why locking it up, getting rid of, putting it in a safe somewhere that the eye can't see or what have you.
These are impulsive means that can lead to lethal outcomes. So we definitely want people to be mindful that if there are a lot of these things should be locked up anyway, just to reduce risk generally. But I think when you have some suspicion that your kid might be stressed and showing some of these symptoms, it makes good practice to remove anything that could be dangerous for them from immediate access.
Yep. And even with adults too, because if again, with that thought process and what's going on in that mental, emotional state in the moment, a person is feeling like this is permanent. They're not seeing down the road. And so when somebody's locked in with that, and then there's access, that it just adds more fuel to the fire sometimes. And everybody's different. Not every, and everybody, sometimes it doesn't get to this point, but it's best to minimize the chance and the risk. Having another risk factor is having a serious chronic medical illness, gender. More women than men attempt suicide, and men are nearly 4 times more likely to die by suicide. History of trauma, abuse, history of traumatic experiences such as sexual violence or severe episodes of racial prejudice, violence, bullying, prolonged stress, a recent tragedy or loss. And it may not even be, the loss may not be of a loved one. A loss can be of a school or work or something that is important that is no longer there.
And I want to add to that, Amber, the bullying. I think that's a loss. When we think about teens and young adolescents or pre-adolescents, you're thinking about what they're going through that is their life tragedies would be I got excluded by friends at the lunch table, and I'm feeling excluded, and that's a relational bullying behavior that can really weigh on a child. And if they feel that their whole social group has rejected them, that's a significant factor of strain. Changing schools, losing a friend group. Those are, and I think about family changes, separation and divorce, loss of a family member, a move away from family, loss of a parent or grandparent. Those are all important life changes that kids are not always equipped to deal with. And they may not talk about unless they're asked about some of these things, how they feel.
And this, again, COVID-19 brought a lot of these factors out to the forefront for a lot of young people, and not being connected. I mean, that's the time of teens is your social group, is getting out, exploring your world, figuring out who you are, and exploring your choices and whatnot. And COVID-19 really put a damper on that in a very very compounding way.
It did.
Yeah. And so, oh, go ahead.
I was going to say, I think the last one on the list was lack of access to mental health treatment.
Yes.
As a risk factor. And those it's a pretty lengthy list, but I do think, any one of these things is not necessarily going to move a person in that direction, but we're looking at the more check boxes that you would have on that type of list. And if people are interested in finding this, you found it on the National Institute of Mental Health website that's available for people to go to. We can put some of these resources in the text box too with the talk. But I think that having more check boxes would be kind of raising the risk status, if you will. Alternatively, one of the other important things to look at is the protective factors. Amber, tell us about some of those, because those kind of balance out the risk.
Right. And if I may, before the protective factors, and another piece that we can put in is, so if I'm an individual or if I'm a family member, where do I call? What do I do? So there's a national suicide prevention hotline, and it's 1-800-273-TALK. And it's also in Espanol, which is 1-888-628-95. Oh, I'm sorry, 9454. And again, that's for Espanol, 1-888-628-9454. And then there's also, which I did not know, which I think is, which is awesome. There's a text hotline as well, which is also hello, which really is great because it's alarming. It's 741-741. And so maybe we can include those as well.
And those are listed on our resource page on our website. I'll give that at the end. But the text one is wonderful because if we think about kids are texting now, they don't want to call people. It's too stressful. But you will get in touch with a professional crisis worker who is experienced in managing suicidal risk. So that's a beautiful thing. And, it is a good, starting point for some people who are feeling overwhelmed and not able to access another person in that moment. So we like to have that information available. Let your kids know about it. In the event that they need it, they may not, but just let them know.
Absolutely.
So protectively, what are we looking for, Amber?
Well, NAMI, again, which is the National Alliance for Mentally Ill, has identified the protective factors as effective coping and problem-solving skills, strong social and family connections, access to quality mental health care, support from religious or social communities, lack of access to means to self-harm. And so even if you may be seeing this and you're like, I don't have insurance, or I don't have the access like people who have private health insurance, I would like to tell you there are places out there that will see you. And so, and we're never alone.
And when I think about this, the protective list is a lot shorter, but it also has a broad scope. So let's think about what are those social connections that can be, close friends, supportive family members, compared to a very chaotic family system where kids don't feel safe talking about these things with family members. So having that safe communication relationship with your kids where kids feel that they can approach you in a non-judgmental manner is going to be a protective factor. And having somebody in their family, an aunt, a sibling, somebody that's
Coach.
safe for them to talk to, having a supportive peer group, having connections at their school, having a job where they feel connected to coworkers, volunteer activities where they feel connected, church communities, extracurricular activities. These are all areas where social connections are considered protective factors for that individual.
And Lisa, are these protective factors also for adults too? So if there are adults that tune into this, like, hey, I'm really curious about this.
Well, and we think about that, how COVID created such a higher risk because our social communities and our social outlets were restricted, not only for kids, but also for adults. We had adults saying, I used to go to this, community activity, art forum every week, and now it's closed. And I'm not in my art community anymore. I'm not in my musical community. I can't play in the band. I can't go to mass and see people and have those conversations after our religious services. So these are all ways that people have felt connected and cared for within their social environments. And I think when we see those active, we view those as these people are having more of an offset for risk. They have a reason for being. They have a reason to get out and go places, even when they're feeling low and hopeless. It pulls them out of that. People that are isolated aren't getting that interaction and validation and support. And it's putting their risk at a much higher state for hopelessness.
And as a substance use counselor, what is absolutely fascinating is there's 24/7 AA, NA, all different types of 12-step groups out there that are online, and you can attend throughout the world. I had a client trying to get his motivation. He goes, I'm going to meetings in New Zealand and I'm connecting with people all the way across the world. And he went on all the time. And then it got other people. It's like, what are you talking about? And then an older lady, when I was working with more in the substance treatment, she also found that these online AA meetings were really helpful. And it also helps minimize the barrier. And so she ended up finding a sponsor in Madison, Wisconsin. And so that's what's great. In some ways, COVID-19 was definitely a very big stressor for all of us. At the same time, it also brought people a way to find support. In a way that, you know what I mean, to help break that isolation, social withdrawal piece too.
And another piece that I want to add is the value of social groups, social support groups in general, not just for AA and substance use, but also just generally. I think people are finding loss groups and grief groups. It's a way of connecting with people with similarities and in finding like hope in other people are overcoming these challenges. Maybe I can do it too. And I think that's another really important piece versus people who are isolated and feeling hopeless and they're not seeing any light at the end of the tunnel, if you will.
Yep. And NAMI also has great support groups too.
Yes.
For young people and parents as well. I just want to put that out there as well. So we're never alone. There's a way to connect.
I think as we are kind of getting close to our time here, let's talk importantly about the do's and don'ts of how to talk to individuals who might you are suspecting might be demonstrating some signs of risk.
All right. So let's hit up the don'ts first. So don't keep secrets, and we've already knocked that out earlier on the why with that. Don't point out other life tragedies that are going on right now as we speak, which is very sad, to show the person to be thankful. That does not help. Ignore the warning signs or tell the person to get over it. Don't say, I know how you feel. That's sympathy, not empathy. Brene Brown has a great video on the difference between sympathy and empathy. It's only 2 minutes. Don't dare the person. Don't ask why. It's not about the why. It's about what is going on. How can I empathize with this person? Don't ask. Don't shame. Don't belittle. Don't act defensive. Don't act shocked, even though you may feel shocked, because even as clinicians, hearing somebody when we all have our own, what really challenges us, it's important to show that empathy. Refuse to talk. Don't pick a fight or have an argument. This is not about you.
Yeah, I think that's one of the things that people might feel defensive or anxious hearing this information. And some of these reactions make it about your feeling of discomfort, which can be very invalidating to the individual who's trying to disclose to you how they're experiencing things. It doesn't, we don't have to understand it in the context of why are you so upset about this particular event? It's you are upset about this particular event. Help me understand how this is affecting you. And that makes it about them. And when we think kids need attention, people need attention, it's giving them attention for how can I help you? Help me understand.
Yes, I like that.
And that's very validating.
And even saying, I'm confused right now. What do you mean? Instead of, well, what do you mean by that? There's a way of conveying, like, I am so confused. Like, where is this coming from? There's a way of showing that authenticity to the person, or to even say, I really don't know what to do, but here's what I do know. Well, why don't we go together and go to, or let's call Konick and Associates, or let's call the hospital for a risk assessment. Let's see what's involved before we just go. And you're trying to get the person out of that hole where they're buried in.
So what should we do? Are there other do's? We have a nice list here for you also.
Sure. Do be aware. Learn the warning signs. Get involved. Be available. Show interest. Show support. Not just, a lot of times people wait for the crisis or whatever. No, it's on the day-to-day. Show an interest in the person's life. What's going on? Ask if he or she is thinking about suicide. Again, having that direct communication. Be direct, talk openly, freely about suicide. Be willing to listen, allow expressions of feelings, and accept the feelings. Be willing to be non-judgmental. Don't debate about this, whether the suicide is right or wrong, or the feelings attached that are good or bad. Don't lecture on the value of life or religion or any other very value type things. It's trying to meet the person where they're at. Say, I'm here. Express worry and how you don't want that person to die. Point to resources. Again, remove the access to drugs and lethal methods. And tell someone, tell a teacher, caregiver, responsible person, get them supportive treatment.
Yeah, those are, I think, great ideas. And it kind of comes to the idea, too, of, sometimes when kids will disclose that they are at risk and we come up with a safety plan and parents are anxious, of course, we as clinicians are also very uncomfortable. I share that with the client. This is a scary, this makes me uncomfortable. I want you to be safe. I want you to understand that even though things might be hard to sort out today, let's walk this path together. Right. Let's, work with me on this first. Let's see if we can navigate this problem. Give me a couple of weeks and let's reevaluate the situation. And we were kind of making them future focused, giving them some coping skills, having them experiment with those and say, let's reassess. We're teaching them problem solving skills. One of the things I think that kids will often complain about is, parents are asking me every day if I'm feeling suicidal. We want to talk about it. We don't necessarily need, I think parents need to get supported in this process too. So when we're working with families, we're working with them together. This is a treatment approach that is an intervention that requires us to work together with the child and the parent. So the parents are being supported through this. And your level of care assessments and interventions, regardless of what level of care you're getting, whether it be private practice, in school, at a hospital setting.
Yep.
You want to be working in collaboration with your child's treatment team.
And ask questions, because we as clinicians like questions. So ask and get the number of who's involved, and, and to be able to talk and share.
I would like to add here before we close for today,
Yes.
The different levels of care. So, I think immediately taking a child to a hospital because they said that they've been thinking about risk isn't always necessary. It's certainly something you can do. But, we at a practice setting, or what we consider outpatient treatment, we can do an assessment of a child at that level of care if there's not imminent risk or immediate risk, and the individual is able to agree to safety planning, and we're able to work with parents on that. The other levels of care would be hospital-based programming, and there's different levels even within the hospital. So people are afraid that if I take my kid to a hospital, they're immediately going to admit them to the hospital, and that's not necessarily the case. Amber, talk about that. You've worked in all levels of care at the hospital setting. I've worked in some of those levels of care as well. Tell us about a level of care assessment at a behavioral hospital and what that would look like, or even at an emergency room, because they would make that referral if it was imminent risk. Tell us about those. I'm thinking about inpatient, partial,
Yes.
and IOP.
Yes. So sometimes people make an appointment, or let's say there's a crisis and I need to get my loved one to get checked out. So when you go there, they're going to be asking a series of questions. Now, over the years, if you go to the ER, I've heard of that it's a very complicated process, that I had to sit and wait and whatnot. So be prepared, because ER times and what's going on, a lot of times you're going to be sitting and waiting. Now, with that, a person is going to be, just like what we covered, the warning signs, risk factors, and protective factors, because not everybody who goes to the hospital are going to get admitted. Not everybody is going to get a level of care and say, hey, you need to go to outpatient. So you don't know. And the job of the person who's doing that assessment is to gather a lot of information. And again, earlier in our talk, when you said it's having these frank, direct questions where you may be shocked as to how this person is asking these questions. Well, the person who's sitting there, from my experience, in some ways likes the person to ask these direct questions, because they're finally able to get out what is going on, a way of understanding. And and then they also want to explore what's been going on, substance use, trauma, what's going on in all different elements of the person's life, to get a full, accurate assessment to diagnose what's going on.
Yes. And I think that once that level of care assessment at the hospital level is made, they're going to give you input about whether if the individual is at immediate risk of safety and and they don't think it's safe for them to leave, then that would be an inpatient. An inpatient is brief crisis management and stabilization. It's short term. That person would then be discharged to a level of care like a partial hospital program, which is a day program, and they would be going during the day for several hours, let's say 8:30 to 3 o'clock, similar to a school day, and they would go home, and you would be working on skills in groups and family work and coping.
And it's having a consistent schedule, because a lot of people, young and older, that the schedule routine just goes out the window. So sometimes people are like, well, I got to get up, I got to do this and whatever. Yeah, it's getting the body and the mind back again. Mm-hmm. And that's why it's consistent. That's why the program goes for a certain amount of time.
Yes, and that's usually a few weeks, and then they may be discharged to an IOP program, which is an intensive outpatient program, which is usually a few hours after, depending on the program timing. It could be several hours in the afternoon after school, and the child would go to school for part of that day. And they usually do have school interventions included in these programming, so the kids are not missing excessive school, and they're also on a medical leave, so they usually will work with your school to get you transitioned back to schools, and not have the kids overloaded with work. And that's one of the bigger concerns for kids and sometimes for parents, is they're going to fall behind. And that's integrated into, we want wellness first. They're not going to be available for academics if they're not emotionally stable and healthy. So we're working on wellness and transition and then recovery. So then that's when that process would step down back to seeing your regular therapist 1 or 2 days a week, and working in collaboration with your school to make sure that everybody's on the same page for safety. So,
can I also add, inpatient and PHP, a lot of the programs you're going to get assessed medically, psychiatrically by a psychiatrist. You're going to be assessed by a nurse, a dietitian sometimes, what's going on, again, because of depression and eating and sleep and underlying medical conditions and whatnot. So that's another great way to understand that. And a lot of times people are like, well, I just want to get on a med. Well, a medication doesn't just do that. You got to have medication and counseling. It's a relationship. It's a pair together, because, okay, the medication is working in my brain and getting my chemistry and getting everything, balanced again. Now I got to have the tools. What are my tools? What are my techniques? So that's why there's a relationship between those two.
Yes, I agree. And I think with teens and kids, we're talking about group support as well. So they're hearing from other teens that are dealing with similar issues and maybe at a different stage of treatment, who have had some recovery and are able to help boost that supportive network. So there's a lot of layers to this process. And it generally can be very effective because we're talking about multiple layers, interdisciplinary layers of care, and really rounding the school back in, having family involved. So we're really looking at targeting these and moving those protective factors up and reducing those risk factors in an overall care plan.
Yep. And hobbies are also another really good, important part to this too, is what are you doing for fun? Because sometimes we form a relationship with those symptoms and whatnot, and it's really hard to look at life and myself having hobbies and leisure interests. So that's also another component to a lot of programs and in counseling too.
Well, I'm going to wrap it up here, Amber. We've been,
Awesome.
I think we've covered all of our areas. If anyone has additional questions, please feel free to reach out to us. You can find some of these resources on our website, which is www.konickandassociates.com. We have a resource page. This video will also be posted there if you want to view. It'll be posted on our Facebook Live and on our YouTube channel. And our information, if you need to give us a call for more information or make an appointment with Amber or speak to one of our counselors, it's 630-206-4060, or email us at info@konickandassociates.com. Thanks for tuning in. Thank you, Amber, for all of your insights and information. And please feel free to contact us if you have additional questions. Thank you for tuning in. Bye.
Bye-bye.